Chairperson and Mr. Moderator, and all protocol observed, thank you for the opportunity to make a brief intervention. And I wish to make just 6 quick points. The first one is poverty and underdevelopment fuel diseases, and diseases facilitate poverty and underdevelopment, and so the vicious circle. The global community therefore needs to decrease global levels of poverty, especially given the escalating food prices, the fuel crisis, including the climate changes. TB is one such example, which we now all know can be cured even in the face of HIV. Prevention of the spread of TB and HIV should be our priority through, amongst others, social mobilization, improved nutrition, ensuring food security, provision of proper housing, improving infection control in crowded places such as public transport and health facilities, and decreasing defaulter rates. With respect to infection control, South Africa has developed and is in the process of implementing infection control strategies in various areas, and we've made available through the Department of Health $53 million to strengthen our response to MDR and XDR, including infection control, as well as strengthening the trace of defaulters, and thus reduce TB defaulter rate to less than 7% by the end of this year, as directed by the President of the Republic of South Africa, President Thabo Mbeki. The Umsinga district, where XDR was first diagnosed, reports today a 0% defaulter rate. And I think we're very proud of this district. And consequently, an increase in the cure rate, and this should be replicated in the whole country. TB and HIV integration is possible, as indicated by our efforts which started in 2002. Currently, in all our health facilities, in all our health districts, there are facilities implementing TB and HIV integration efforts. The biggest challenge, Chairperson, is the fact that TB diagnosis and treatment is initiated at primary care level, whilst ARVs are initiated in the accredited facilities in our country, and these are largely in hospitals. In addition, HIV patients with CD4 counts of less than 50 who are also diagnosed with TB are first treated for TB at least for 2 weeks before they can be initiated on ARVs. Patients with CD4 counts higher than 50 and who are also diagnosed with TB are only started on ARVs when their smear is negative, and that's usually 2 to 3 months after the initiation of TB. In part, Chairperson, this is indicative of the need to strengthen our health systems, and we are exploring creative ways to do this. We must provide nutritional supplementation to patients with TB and HIV and other debilitating illnesses, but also ensure food security in the medium to long term for all our people. Finally,
excuse me, sorry, could you come to the end? We've got so many other people.
Just 2 sentences and I'm finished.
Go to the main point at the end of your speech, because all these other people won't get to speak. Sorry to interrupt you, but it was 5 minutes.
Finally, we need new drugs and diagnostics for TB, including drug-resistant TB. And in this regard, I'm happy to announce that South Africa has participated recently, a recently completed pilot of new diagnostic technologies for drug-resistant TB, and this will be launched in South Africa shortly. And I'm proud that the public sector laboratories in South Africa and our patients have been able to contribute to this breakthrough, but wish to urge the international community, especially the industry, to do more in this regard. And thank you very much.
Thank you very much there from South Africa.